Hello and welcome to GastroVision. I am Dr. Qazi Suhail. I am working at Government Medical College Srinagar and we have started a series on hepatology and today is lecture number 7. Today's topic is iron metabolism and hereditary hemochromatosis. So let's start with iron metabolism. So we have two types of iron that comes in intestines. One is heme iron and another is non-heme iron. Heme iron is derived from animal proteins. It undergoes oxidation and is converted to hemine. Now this hemine enters enterocytes. We don't have a specific transporter for this heme iron to be transported into enterocytes. And inside enterocytes, this hemine is acted upon by heme oxygenase and is converted to Fe2 positive, that is ferrous form of iron. Or with the help of hepcidin, it is converted to ferric form, that is Fe3 positive form. This ferric form, that is Fe3 positive form, is transported to circulation or circulatory system via ferroportin. Ferroportin is an export protein that transports Fe3 positive from enterocytes to circulation. And in the circulation, this Fe3 positive form binds to transferrin. Now coming to hepcidin. Hepcidin is a copper containing ferrooxidase like ceruloplasmin and it converts Fe2 positive to Fe3 positive as I have already mentioned. Now coming to ferroportin is the only iron export protein. This ferroportin and it combines with hepcidin. It undergoes internalization and is degraded, thereby helping in regulation of iron. Now coming to non-heme iron. Non-heme iron, its absorption is inhibited by phytates, phosphates, calcium, zinc, and some dietary fibers, while as its absorption is promoted by ascorbic acid, food, cytochrome B. These are the compounds that absorb, and it is absorbed in Fe2 positive form. Now this Fe2 positive, that is divalent ion, it is transferred inside enterocyte with the help of a transporter that's called DMT1. It's a divalent metal transporter. And then it enters enterocyte, it undergoes the similar processes that occur with heme iron. The expression of DMT1 is increased in iron deficiency states. Now coming to hemochromatosis. Hemochromatosis is a disorder of iron metabolism. It's a hereditary disorder with autosomal recessive inheritance. And in this disorder, there is increased absorption of iron, which leads to increased tissue deposition of iron. Now, coming to the types of hereditary hemochromatosis. We have four types of hereditary hemochromatosis: type 1, type 2, type 3, and type 4. Among them, type 1 is HFE related hereditary hemochromatosis, while as type 2, type 3, and type 4 they are non-HFE related hereditary hemochromatosis. Type 2 is further divided into two types, type 2A and type 2B. Depends on the gene involved. As I have already mentioned, type 1 is HFE related. That means the protein that's involved is HFE protein. We will be discussing HFE protein later, but let me tell you one thing here. The mutation here in HFE related, that's type 1 hereditary hemochromatosis, is C282Y. It can be either homozygous or it can be heterozygous. In heterozygous, we have C282Y with H63D heterozygosity, or there can be other HFE related mutations. In type 2A, there is a mutation in hemojuvelin HJV, In type 2b, there's a mutation in hepcidin, that's HAMP gene. In type 3, there's a mutation in transferrin receptor 2, and in type 4, there is the mutation in ferroportin, or the gene involved is SLC40A1. Now coming to type 2A, in this, the gene involved is HJV. Hemojuvelin is the most common non-HFE related gene that is involved in hereditary hemochromatosis, and it regulates hepcidin. Hemojuvelin is actually a co-receptor that regulates hepcidin via pathway BMP-SMAD pathway. Now coming to type 4, that is a hereditary hemochromatosis where ferroportin mutation is there. Now, here is an important thing that needs to be understood here. There can be either loss of function mutation or gain of function mutation. Loss of function mutation occurs in macrophages. That means there is decreased ability of iron to be transferred from macrophage to circulation. While as in gain of function mutation, there is increased transport from enterocytes to circulation. Now, as I have already told you, we will be discussing HFE related protein later. What is HFE protein? This HFE protein is physically associated with beta 2 microglobulin, and the bond between them is disulfide bond. When there is a mutation in this protein, it leads to reduced interaction of HFE protein with beta 2 microglobulin. As a result, there is decreased presentation of this protein at cell surface, and there is increased retention of this protein inside endoplasmic reticulum, and thus increased degradation of this protein. Now, when there is increased degradation of this protein, there is aberrant hepatocellular sensing of plasma iron, because HFE is important for sensing plasma iron. As a result, there is decreased concentration of hepcidin. Hepcidin will decrease drastically, and thus there is increased absorption of iron. Now, what is hepcidin? Hepcidin is actually a hormone which is an iron regulatory hormone. This hepcidin binds to ferroportin, which I have already mentioned. It binds to ferroportin, and this, after binding with ferroportin, undergoes internalization and eventually degradation of ferroportin. Another thing that should be noted here, interleukin 6 that actually upregulates this hepcidin. That's why you can see decreased iron absorption and thus anemia of chronic disease. And it should be noted this iron-induced hepcidin regulation is through a pathway that is PMP6 signaling pathway. And one more thing, that's reactive oxygen species. You might have seen in reactive oxygen species there is increased iron load that is secondary to inhibition of hepcidin expression by reactive oxygen species. That's why you see in chronic hepatitis C and alcoholic liver disease there is increased iron load. So what is the mechanism of injury to hepatocytes by iron that we call iron induced injury? What iron actually causes? It causes lipid peroxidation of membranes. When there is lipid peroxidation of membranes, there is impairment of membrane dependent functions like mitochondria. As a result, there is hepatocellular injury and death of hepatocytes, which leads to copper cell activation and eventually stellate cell activation, which leads to fibrosis and eventually cirrhosis. Now, coming to the clinical manifestations of hereditary hemochromatosis. The average duration of disease, that's hereditary hemochromatosis, is around 10 years before onset of symptoms. Starting from the symptoms that are related to brain, that can be either fatigue, hypopituitarism, and there can be hypothyroidism in patients with hereditary hemochromatosis. due to deposition of iron in the thyroid. And there can be cardiac abnormalities, like there can be rhythm abnormalities, there can be rhythm disorders, or there can be cardiac failure. And you may see DCM may be present in around 15% of the patients having hereditary hemochromatosis. And due to deposition of iron in pancreas, patient may have diabetes mellitus, and it may be present in 50% of patients with hereditary hemochromatosis. Due to deposition of iron and melanin in the skin, there are skin changes like melanoderma, there can be skin dryness, and there can be hyperpigmentation. The condition we call bronze diabetes. Now coming to liver. The patient may have hepatomegaly, the patient may have cirrhosis, and cirrhosis may be present in 2 to 12% of patients, and it may progress to hepatocellular carcinoma. There are nail changes in the form of white nails, flat nails, and koilonychia. And there is involvement of joints like arthralgias that may be present in 40% of patients, and there can be osteoporosis also. The most common joint that's involved is second or third MCP. And there is susceptibility to infections in hereditary hemochromatosis, like there is susceptibility to listeria, there is susceptibility to Yersinia, there is susceptibility to Vibrio. Now coming to the diagnosis of hereditary hemochromatosis. We have three things in diagnosis. One is serum markers, another is liver, and the third is mutational analysis. In the serum, we see iron level, and we see transferrin saturation, and we see serum ferritin. The iron levels are in the range of 180 to 300 micrograms per deciliter, while as transferrin saturation is greater than 45 centimeter, that may be in the range of 45 to 100%. And the ferritin levels are in the range of 300 to 3000 micrograms per liter. For iron, it's microgram per deciliter, while as for ferritin, it's microgram per liter. And in liver, we see three things. One is iron staining, iron concentration, and hepatic iron index. Iron staining is with the help of Prussian blue staining. It is 3 plus or 4 plus in hereditary hemochromatosis, and iron concentration ranges from 300 to 30,000 microgram per gram dry weight. And hepatic iron index may be greater than 1.9, which is less than 1.1 in normal individuals. And one thing should be noted, the earliest phenotypic manifestation is transferrin saturation greater than 45%. And this is the earliest phenotypic manifestation in HFV-related hereditary hemochromatosis, and is more sensitive and specific compared to serum ferritin levels. The mutation analysis I have already mentioned. There are two types of mutations, HFV-related and non-HFV-related, which we have already discussed. The stain used for iron staining is Prussian blue stain, and you will see typically in periportal hepatocytes, this type of staining you will see in periportal hepatocytes, and in Kupffer cells you will not see any iron staining. And it should be noted here, the iron staining is only in the periportal hepatocytes. Now, is there any role of MRI in hereditary hemochromatosis? Yes, it can help us in distinguishing hereditary hemochromatosis and secondary iron overload. In hereditary hemochromatosis, you can find low signal intensity in liver, but there is normal signal intensity in spleen. While as in conditions with secondary iron overload, low signal intensity because of iron deposition will be present in liver as well as in spleen. Now coming to the management of hereditary hemochromatosis. And it is here important to mention all first degree relatives of hereditary hemochromatosis and individuals with suggestive symptoms and the subjects with unexplained liver disease, they should undergo transferrin saturation and ferritin levels. It's very important. If transferrin saturation is less than 45% and serum ferritin levels are less than 300, then you need to reassure the patients it's not hereditary hemochromatosis, or you may retest later. Now, if the transferrin saturation is greater than 45% and it is associated with serum ferritin levels that are greater than 300 micrograms per liter, then you have to do gene analysis, that is HFE genotype. If it is normal, you can consider it normal, or it may be non-HFE related protein that's involved. If this mutation analysis is positive, you have to concentrate on two things. One is serum ferritin levels and LFT. If LFT is normal and serum ferritin levels are in the range of 300 to 1000, then the patient should be sent for phlebotomy. Second condition is if the LFT is normal and serum ferritin levels are less than 300, then you do not need to do anything, you just retest after 1 to 2 years. If LFT is abnormal and serum ferritin levels are greater than 1000, then liver biopsy is indicated to detect iron overload. And if there is iron overload, then this patient should be sent for phlebotomy. Now, coming to phlebotomy, this phlebotomy should be around 1 unit of whole blood, that's around 500 ml. And what is our target? The hematocrit should be less than 37%. This should be our target. When this target is achieved, you can go for maintenance phlebotomy. Our target should be transferrin saturation less than 50% and serum ferritin levels in the range of 50 to 100. The target which I have already mentioned, it should be transferrin saturation should be less than 50%, and thereon you can go for maintenance phlebotomy, that is 500 ml every 2 to 3 months. Now, what is the role of chelation therapy in hereditary hemochromatosis? Patients who can't tolerate phlebotomy, like older patients, those patients having underlying severe anemia, and those patients with dilated cardiomyopathy, they should be given chelation therapy. In the chelation therapy, we have deferrioxamine. It is given in the dose of 20 to 50 mg per kg per day, and it is given 5 days a week. It is given in continuous subcutaneous infusion with portable pump. We have another drug that's oral, that's deferricyrox, that is given in once daily dose. Now, what's the role of liver transplantation in patients with hereditary hemochromatosis? 5-year survival is not that much good. 5-year survival is low, that is 35 to 55%. This may be secondary to infections, this may be secondary to HCC, this may be secondary to cardiovascular complications. Now coming to family screening in hereditary hemochromatosis. And we should go for genotypic as well as phenotypic screening. Phenotypic means serum ferritin and transferrin saturation, and this should be done in all first degree relatives of hereditary hemochromatosis patient. If mutation is positive, then go for serum ferritin levels. If they are greater than 1000, then liver biopsy is indicated, as I have already mentioned, to detect iron overload and to plan the further treatment.